evaluation of the presence and extent of cancer.
Of course, the bizarre thing also is you've got 2 PET machines in this hospital and you've got a cyclotron, and you're strictly limited to finance for 1 PET machine, even if the other one, you know, if it breaks down you can't use the other one.
Yeah.
And you've got a cyclotron there where you've got government money coming in happily to see what it can do. I mean, how do you rationalise that?
Well, I think there's a significant disconnect between decisions by one arm of government and the other. On one hand, they're telling us that they're not convinced that this improves the health of Australian patients with cancer. On the other hand, they're funding us to develop new PET radiopharmaceuticals that will evaluate a whole raft of new indications for PET. You can't have both, in my opinion.
And then, how did you feel when Westmead suddenly got one? Just popped out of the blue?
Yeah, I guess it's very disappointing. We've been fighting, we've been doing this on the shoestring for many, many years. We've received minimal funding from the federal government over the years in terms of establishing the equipment and the infrastructure that we have here, and yet a group that have really had very little experience in PET given a major amount of money and told that this is a wonderful technology by the Health Minister.
Well, which happened before the results of the trial that they said was essential.
That's correct, yeah.
What do you think?
Well, I don't know what to think, really.
I mean, why didn't you sing out?
We were constrained by a confidentiality agreement, an enduring confidentiality agreement that we had to sign at the start of this process. So I went through official channels. I complained to the chair of the Medicare Services Advisory Committee, and when unsatisfied with the response that I received through the executive of that group, I went to the Secretary of the Department of Health and made my complaints clear.
Okay, I'm going to ask you it again, just to get it tighter, but well, this report came out, you read this, you were alarmed, you knew your colleagues were going to give you heaps. I mean, why didn't you sing out? Why didn't you go to the media then?
I couldn't speak publicly because I was constrained by a confidentiality agreement that I signed when I joined the committee.
And so what did you do?
I contacted the officials involved in the process. I complained to the chair of MSAC and to the Secretary of the Department of Health.
And why are you speaking now then?
Because through the recent Senate hearing, the information has gone on to the public record and I can now speak about it.
Okay. Do you think this could happen again? I mean, what are the implications of it?
I hope that it never happens again. I hope that the Senate finds that the organisation of the Medicare Services Advisory Committee needs to be fundamentally changed.
What about the implications of this internationally? I mean, can you just give me some idea of how big an expert you are and your colleagues in this thing, and how the PET decision in Australia may have affected other places like New Zealand, Canada, for example?
I'm internationally recognised as an expert in PET. I'm invited to speak at international meetings throughout the world. I regularly tour the world giving lectures on this technology. I'm on the editorial boards of all the major nuclear medicine journals and also on major oncology journals now. So I would say internationally I'm one of the best recognised people in this field. Has this report affected decision makers elsewhere in the world? Absolutely yes. We know that the primary conclusion of this report was quoted almost verbatim in several other health technology reviews which followed it, and it was used to justify their findings, again, that there was insufficient evidence of PET's clinical and cost effectiveness to warrant funding.
And yet it wasn't your finding.
It wasn't our finding, no. It wasn't our advice. Our advice was, in the 6 indications that we looked at, PET should be funded because there was evidence that it was more accurate and appropriately influenced management.
Why do you think this has happened?
It's a good question. I suspect that the government believes it was being responsible with how they're spending healthcare dollars.
But you've never got anywhere in all your complaints and everything. I mean, it's, you know, Is there some vested interest? Is it a cock-up? Is it what is it?
I wish I understood the motivation, because we know that the government has data that PET can potentially save money by preventing unnecessary surgery, by better selecting and delivering radiotherapy, by better choosing drugs and understanding at an earlier stage whether those drugs are working or not. By doing that, you save money.
Okay, and let's look at that. With patients here, I mean, what sort of dilemma do you and the patients face at the moment without funding? I mean, if we look at bowel cancer, if we look at breast cancer, can you briefly describe how useful it is, but also what it means to their hip pocket?
Well, we've made a very conscious decision here at Peter Mac that patients who are going to be treated curatively deserve access to this technology. That's why we run a second unfunded PET scanner. The one camera does the Medicare eligible patients, the other camera does those patients who need the technology. Unfortunately, if patients aren't from Peter Mac, they have to pay for their PET scans.
And how much is that costing them?
It costs, depending on the indication, between $800 and $1,000 for their scan.
It's a lot of money, but somebody with cancer, I suppose they pay it.
It is a lot of money, but when you compare it to the expenditure and the choices that are made, it's money, I believe, that's very well spent. Unfortunately, not everyone has that ready cash to pay for a PET scan, and they make choices based on the cost of that technology.
So what happens with them?
That they have decisions made on their care which I believe are potentially flawed by inadequate evaluation of the extent and the presence of their cancer.
Let's just look at prostate cancer and breast cancer. I mean, how useful, can you explain briefly why PET makes such a difference?
Breast and prostate cancer are respectively the most common cancers in women and men, a major cause of death. However, the information that PET gives is unique in those two diseases, because it's not about counting lumps. It's about characterising those lumps. How active are they? In Michael's case, it showed us before any other test the presence of recurrent disease and exactly where it was. No other test was able to show that, and that manifestly changed the course of his disease.
In what way? What would have happened if you just used conventional technology?
Michael had had an operation on his prostate after he was picked up on a screening PSA test. The PSA level fell to a level not quite normal, just above normal. Traditionally, he would have then gone on to receive radiotherapy of his prostate on the assumption that there was a small amount of prostate cancer left in the area of the surgery. The PET scan was performed after a negative CT scan and after a negative bone scan. The PET showed quite clearly that lymph nodes in the pelvis and abdomen were involved. This was back in 1999. And because of that, instead of having radiotherapy to his prostate that would have ended up with significant side effects and benefited him not at all because he had no prostate cancer left in the area of the surgery, he received systemic therapy with hormones, which kept him in remission until early this year.
So we've seen a couple of cases and everything, but I mean, you know, what do they represent? I mean, how big is this?
It's not just anecdotes like those of Ruth and Michael, who clearly benefited from this technology in a huge way. There are data from multiple studies from places like Peter Mac and other leading cancer centres published in major journals over the last 10 years that have demonstrated that PET can change management in more than 50% of patients with various important forms of cancer.
And overseas, I mean, in the US, it's actually been cited as a thing that's helped, you know, a landmark in the fight against cancer or something.
Absolutely.
Can you describe that?
I went to the American Association of Cancer Research this year to give a plenary lecture on the role of PET in sarcoma, and was interested to see on a display of the landmarks in cancer of the last 100 years that PET was there as 1998 being authorised by the FDA as a technique for evaluating cancer.